So let's start off with this condition. These are my declarations of interest. So we know that the corneal innervation comes from the midbrain through the trigeminal ganglion and the ophthalmic division of the trigeminal. It terminates at the back of the eye around the optic nerve as the short and the two long posterior ciliary nerves. These then travel between the sclera and the choroid anteriorly, and at a variable point before reaching the limbus, they break up into branches. They enclose the whole globe, and radial branches then go to form the pericorneal plexus. From the pericorneal plexus, they will then enter the limbus, and this is a stain called acetylcholinesterase stain of the whole mount of the cornea, which will show you the nerves as brown. And they might be single, or they might enter single and immediately divide into two, or may come straight as two. And then they move centrally and anteriorly. So they're going from the mid-stroma into the anterior stroma towards the Bowman zone. And you can see that one coming here, and they actually pierce the Bowman's layer and end in a tiny bulb, from which the subbasal plexus or the neurites of the subbasal plexus arise. As you can see here, there are many of these little bulb-like structures. So this is a normal finding of the termination of the nerves that we published in 2009, and then the whole network forms from there. Now that subbasal plexus is in the coronal plane, but from it vertical branches go up, and they are between the cells and actually terminate in modified nerve endings or free nerve endings intercellularly as well as intracellularly. That's what you see over here. Now that innervation of the cornea makes it the most sensitive structure in the human body, 40 times more than the dental pulp, and it's 100 times more sensitive than the skin and than the conjunctiva, and 400 times that of the skin. Now, the nerves serve two functions. One is sensory. We all understand that, taking sensation of the cornea to the brain. But there's also this trophic function, which is very important. So you can imagine a corneal nerve here. It will, through the sensory function, stimulate the Bink reflex and tear production. Both of them are protective reflexes. Tears coming from the tear gland have a lot of growth factors and a lot of bacterial static and bactericidal proteins, and that helps to keep the bacterial flora and maintain the health of the epithelium. The nerves also produce substances called Neuro Mediators. These Neuro Mediators directly are responsible for the health of the epithelium, but not so much the sensory function. It's the trophic function, the health and integrity of the epithelium. And the epithelium in turn produces growth factors, and nerve growth factor is the most important of these, which then helps to support nerve growth, regeneration, and nerve health. So it's a mutually symbiotic relationship between nerves, providing the trophic is also referred to as the nutritional support to the epithelium, and the sensory support, and the epithelium supporting the nerves. Now, the cornea is avascular, yet it responds to any irritation or inflammation with a vascular response, and that vascular response occurs in the perilimbal area. Most of the nerves that are in the perilimbal plexus are vasomotor nerves, so they cause intense and immediate vasodilation, and from there then the inflammatory cells can come out and migrate into the cornea. So the ciliary injection is a local axonal reflex. It doesn't go to the spinal cord, and it's immediate, so that when you irritate the cornea by any means, and bacteria, for example, you get intense vasodilation, cells can immediately come out and try and contain the bacteria. But if you don't have that host immune response, you don't have the host inflammatory response, what you see is the bacterial colonies by themselves growing in the stroma, and that is like a Christmas tree pattern, and that's called infectious crystalline keratopathy. That is bacterial or even microbial fungal invasion of the cornea in the absence of the host response. So when there is no innervation or no nerves, you don't get this host response, because you don't get ciliary vasodilation, and you end up with the bacteria going without the polymorphs or the lymphocytes. Now, one thing you have to realize, like I said, if you look at so far we couldn't see the nerves, so we were not commenting on them. But here you can see in bullous keratopathy, there's a lot of nerve thickening, regeneration, hyper-regeneration, looping and coiling. You can see in a cornea graft patient, some nerves look normal in the plexus, in the stroma, but the subepithelial plexus is missing, and some nerves are very aberrant regeneration, and some places there are no nerves. So this is what we might call a normal transparent corneal graft, but the nerves are completely abnormal. This is again in a patient with chronic, this is in keratoconus. You can see gross thickening of the nerves, and in advanced keratoconus, outside the cone the nerves are normal, but within the cone they are grossly abnormal, very thickened, too many of them, a lot of coiling. So nerve pathology underlying every corneal disease is a very important factor, but because we couldn't see them, we weren't talking about them. But by looking at corneal buttons that we have removed and whole mount staining with acetylcholinesterase, we can pick up these findings, and also by confocal microscopy we can pick up these findings. So this patient was referred to me with what was called lattice dystrophy, but actually these are calcified corneal nerves and those bulbs. Now from the bulb, the neuroids don't have a sheath, so they don't calcify, but up till there they are calcifying, and you can see this calcified pattern of the nerve. So this is how it is normally there. What you will also see is that, again, a very important concept to understand, there will be patients with normal kind of distribution, equal kind of distribution in the right and left eyes, but one eye has zero sensation with the Cauchy-Bonnet aesthesiometer, and the other eye has normal sensation. So how can that be? The nerves are okay, but no sensation. And the reason is this: if the lesion is posterior to the ganglion, more central to the ganglion, then all the sensations from here will be blocked here. They won't go to the brain, and the patient won't perceive pain. But the ganglion is intact over here, and the neurons coming from the axons coming from these neurons will go down and provide the trophic support. The neuro mediators are still being released, so this epithelium will not break down. This epithelium will stay relatively healthy. The same happens with a partial ganglionic lesion. But if the lesion is here, or if the total ganglion is gone, then both sensory and trophic factors are blocked. So sensations cannot go up, trophic factors cannot go down. That epithelium is prone to epithelial defects, to stromal melting, perforation, and develop neurotrophic keratopathy. So, but both of these patients will have very poor or limited or reduced sensation. So when the sensations are reduced, if you can get confocal microscopy done, you can see the plexus, you can say that the prognosis is good, but if there's no plexus, the prognosis is bad. So what is neurotrophic keratopathy? The terms we use: non-healing defects, persistent epithelial defects, slow healing defects, and neurotrophic keratopathy, neurotrophic keratitis, or neuropathic keratopathy. All of these are the terms used. So we say we should stick to one. We call it neurotrophic keratopathy. So in terms of nomenclature, that's what this should be called, although clinically they are interchangeably used with the above. The definition of a persistent epithelial defect is an epithelial defect that does not heal, or heals and breaks down repeatedly. But the definition of neurotrophic keratopathy is a disease related to alteration in corneal nerves leading to impairment in sensory and trophic function with consequent breakdown of the corneal epithelium, affecting health, integrity of the tear film, epithelium, and stroma. And the hallmark of the disease is there is lack or absence of corneal sensation. And number of diseases can cause this condition. As you can see, there can be ocular conditions, central nervous condition, systemic conditions, and genetic here, and a lot of diseases and surgical procedures. Increasingly, cataract surgery, definitely LASIK, PRK surgery, corneal graft surgery, a lot of surgery. In fact, any surgery you name, even squint surgery, can be associated with nerve damage leading to NK. In LASIK, PRK, we do this in thousands, but some patients will have the central SPK, not the lower 1/3. We call it post-refractive surgery dry eye. One patient we had where we were able to look at this cornea of a patient with LASIK, and you can see the nerves are abnormal. These nerves don't always go back to normal. So are we really leaving behind a normal eye is the question. Functionally, it is normal, but the nerves don't regenerate. And You have substrate pathology. Sometimes it's not just the epithelium and the nerve, but the keratocytes become depleted, and that will not allow the epithelium to heal. Here is a Canthamoeba infection in an ex vivo model. You can see the trophozoites are actually, this is a trophozoite of eating the keratocytes. That's a half-eating keratocyte. So these stroma is completely devoid of keratocytes. The epithelium will not heal. You get a non-healing defect. And if there's reduced sensation, then that's NK. So there are two things happening: the actual nerve damage related pathology and the underlying cause related pathology. So you always look for the underlying cause and the clinical features of the underlying cause and the clinical features which are directly related to the nerve damage. And this is just a cartoon to show you how if you get infection, trauma, you get an epithelial defect, that leads to keratocyte apoptosis, neutrophil invasion. Neutrophils release metalloproteases, stromal melt, and when all of this is linked with poor corneal sensation, that's the start of corneal stromal melting. Clinically, we divide this into mild, moderate, and severe, and is simply put, when there is epitheliopathy without a frank defect and low sensation, it is mild. When there's a frank epithelial defect but no stromal involvement, it is moderate. And when there is stromal involvement in addition, again with poor sensation, it is severe. And these are some examples of mild, moderate, and severe cases. Again, just to show the symptoms can be symptoms of dryness, photophobia, irritability, a bit of watering sometimes in the early stages, or reduced blink reflex. All these will be in the early stages, and then later on you will find they become worse, the symptoms. But as the nerve damage increases, the pain becomes less. The patient thinks they're getting better, but they're actually getting worse because there is no sensory input and the pain becomes less. And then you get frank melting of the cornea, as you see in zoster and simplex cases, and then perforation is a big risk. So that is the severe stage of NK. If you do OCT in these patients, what you will find is that whether it is the mild stage or the moderate stage or the severe stage, there is a lot of stromal involvement right from the beginning. So clinically we say epitheliopathy without stromal, in the epithelial defect without stroma, and then stroma in the severe. But actually stromal involvement subclinically starts right from stage 1. And these are some examples of the mild, moderate, and severe. On OCT, you can see the stroma is involved and melted there, but here also a lot of stromal involvement in the moderate stage. Now, we talk about pain with stain, the classic dry eye. We talk about stain without pain. This is NK, a lot of defects but no pain. And then there is this condition called pain without stain. There's absolutely no stain of the cornea. Everything looks healthy. The patient has severe pain. Many of them are suicidal. It's very difficult to treat these patients. So different terms are used to describe corneal pain, but the underlying feature of this neuropathic pain, pain without stain, is the activated keratocytes, which may be again mild, moderate, or severe. And then you have this is, you can see a lot of activation of keratocytes compared to that, which is moderate. This is severe. But interestingly, the subbasal nerve plexus can be either completely absent or reduced or hyper-regenerated nerves. So hyperesthesia or increased nerve sensation, we have no way of measuring. We only can measure reduced sensation, and we have to develop tools to measure increased sensation, because that is the cause for pain without stain. And what is also interesting is you have these neuromas in the corneal nerves. This is a relatively new finding. There are different types of neuromas: spindle neuromas, lateral neuromas, and stump neuromas. And these corneas are excruciatingly painful, but there is nothing on the epithelium to show for it. And we try to put the patient off as saying this is, all functional and it's not real and so forth, but there is a problem. So corneal sensation, we should test by testing all 4 quadrants, ask the patient, and also test the cornea and the conjunctiva, because you can get corneal sensation impaired with normal conjunctival sensation. And some patients will have normal blink reflex, and always test the sensation before you put topical anesthesia. So here are different ways by which we examine, but the cotton wisp is the commonest. And what you'll see here is you're looking in the center, to the right, to the left, and the patient may still have some normal blinks. So if your touch corresponds with a blink, you may think it's responding to your touch. but often you have to then repeat it a few times to show where the patient, this is gross absence of corneal sensation. We'll skip this one again just to show the same thing, top, bottom, right, left. So the point here is that nerves are involved in all corneal diseases. Nerve involvement can cause increased sensation or reduced sensation. When nerve is damaged severely, you can get serious pathology of the cornea. All that is NK, but that is often masked by or compounded by the features of the underlying disease, which may be surgery, herpes disease, or diabetes, or whatever. So that is the background of this condition and of the value of looking for nerves and sensations.